Hi everyone, this is Neel Raithatha, consultant audiologist and director of earwax. Thank you for joining me in my latest video using the iClearScope endoscope. And this is of a patient who attended today, Christmas Eve, and it was an emergency patient. And this is their left ear. This is not the ear that they predominantly attended for. That was their right ear, so do stay tuned. And they, I'll give you the backstory. So whilst before I do that, I'll just explain what I'm doing here. So in this left ear, they've got really dry, crusted wax, dead skin, medially impacted against the eardrum. So I've just instilled some medical grade olive oil spray to help loosen this, and we're just performing microsuction, and we'll extract this in a moment. And when we do, this patient, I believe at the age of 5, had bilateral grommets fitted because they suffered from glue ear, which is a buildup of fluid behind the eardrum. However, the grommets had to be extracted soon afterwards because the patient developed an adverse reaction. Not sure exactly what the adverse reaction was. The patient themselves quite young, but I presume they developed an infection. And I believe either the holes created by the insertion of the grommet, so I think in America you call them ventilation tubes, which essentially they are, but in the UK we call them the grommets or T-tubes, or they developed, the eardrum did heal, because at that age typically if you have a hole in your eardrum it will spontaneously self-heal within around 6 weeks, and they developed glue ear again, which then caused the perforation of the eardrum. But the perforation, either as a result of the grommet being fitted or secondary middle ear infection, didn't resolve. So they had a laryngoplasty, so they had a cartilage and skin graft kind of to patch up the hole in the eardrum. And in this left ear, you'll see anteriorly they've got laryngosclerosis, which is basically scar tissue. It's calcium deposits, it's calcification of the eardrum in the middle fibrous layer. Posteriorly, the eardrum looks quite thin, and we can just see the head of the stapes. So I suspect they have some erosion of the long process of the incus, which is the middle of the 3 bones. The stapes, also known as the stirrup, is the smallest bone in the body, and that's the 3rd bone. So there's 3 bones in the middle ear: the hammer bone, the anvil, and the stirrup. And when sounds hit the eardrum, these bones vibrate, and the stirrup stimulates the organ of hearing. So we're now moving on to their right ear, and they had severe pain. The pain in this right ear developed about a week ago, last Sunday, so a few days ago. It was that severe that they attended accident and emergency. They weren't able to sleep at night, so their ear pain, otalgia, exacerbated at night, so we call that nocturnal otalgia, to the point where they weren't able to sleep in a normal supine position. So instead they were sleeping sat upright, so in a Fowler's position. And the pain began to radiate across the right side of their face and their jaw region, to the point where even eating was becoming really, really painful for the patient. So they went to the accident emergency department, and they were told that they've got some earwax and possibly an ear infection. So they were given some pain relief and told to use sodium bicarbonate earwax drops, and then an outpatient appointment was arranged for the patient to see ENT on the 10th of January, but this patient couldn't tolerate the pain anymore, and they actually saw another consultant in a different discipline, and they were just explaining their ear problems. And unbeknown to me, but this consultant, I think they're a consultant gastroenterologist, I've previously treated some of their family members, so they recommended the patient to see myself, so they gave them the contact details and they booked in today. Now, as you can see, this patient has got otitis externa. Laterally, that plug, it wasn't actually wax, it was dead keratin that had hardened, and I had to remove that using an ear hook, but we had to be really, really gentle in this case, as we always are, but particularly here because this patient was experiencing, as I said, otalgia. Now, when I removed that outer plug, they did feel their symptoms to somewhat alleviate. But this patient is also diabetic, and when a patient experiences severe ear pain or otalgia, particularly at night, and to the severity that this patient was, they couldn't sleep in a normal position and they can't eat, we have to be careful of malignant or necrotizing otitis externa. So malignant or necrotizing otitis externa is a potentially life-threatening ear infection, and it typically occurs secondary to normal otitis externa, so a normal outer ear infection, where then this infection can spread through the ear canal to the surrounding bone, the temporal bone, and it does that typically via the kind of outer third region of the ear canal. So the outer third of the ear canal, the cartilaginous portion, there's some natural openings in the underlying cartilage at the floor of the ear canal, called the fissures of Santorini. So if the skin on top of that is compromised or ulcerated in any way, the infection can seep through the ear canal, through these natural openings of the underlying cartilage. And then this infection can invade the temporal bone, which is the bony part of the ear canal. So the bone, the inner two-thirds of the ear canal is encapsulated by bone, and we call that the temporal bone. And when the temporal bone is infected, we kind of call that osteomyelitis. It's an infection of the bone, and it can lead to bony erosion, and this infection can then spread and invade nearby structures such as a cranial nerve, or if it's the back part of the ear canal, the mastoid bone. It can also affect the temporomandibular jaw joint, so the TMJ. So this patient was experiencing pain in that region, and it can also affect the parotid glands, one of the salivary glands, the front part of the ear canal. If it spreads upwards, it can go to the skull base, so just underneath the brain, which can potentially then cause meningitis, a brain abscess, and even potentially death. And the bacteria that's normally involved in malignant otitis externa is Pseudomonas aeruginosa. So that's a gram-negative bacteria, and it's more susceptible to neutral pH conditions. Now, the ear is typically mildly acidic, so it's difficult for Pseudomonas aeruginosa to take hold in a mildly acidic pH condition. But if the pH level is increased, which can just be by the simple act of water getting into the ear, and this Pseudomonas aeruginosa can actually be present in tap water. Now, gram-negative bacteria are very difficult to treat in comparison to gram-positive bacteria. So gram-positive bacteria, typically the bacteria has a thick cell membrane. With a gram-negative, it has a very thin cell membrane, but the bacteria is then encapsulated in a thick lipid capsule, which makes it more resistant to antibiotics. And with gram-negative bacteria, they can mutate to become resistant to antibiotics. And then once they become resistant to an antibiotic, they can share their modified genetic code with surrounding gram-negative bacteria, so you can basically pass on this information. So gram-negative bacteria can be very difficult to treat with antibiotics, and patients who are most at risk are elderly patients, patients who are immunocompromised, or patients who have had radiotherapy around the ear, so which can cause damage to the blood vessels, and also diabetics. So with elderly patients, immunocompromised and diabetics, it's not only due to, in the case of diabetics, due to a poor blood supply. So when you've got an infection, you need a rich supply of blood to help fight off the infection. But also with diabetics, the natural earwax. Now, we've all got or we should have a natural veneer of wax lining the ear canal skin, even if it's not visible. And earwax is, as mentioned previously, mildly acidic, but in diabetics, the pH level of the earwax is actually more neutral, and if it's more neutral, then the overall ear pH can also become more neutral. And as explained, that gram-negative bacteria, Pseudomonas aeruginosa, which is heavily linked with malignant otitis externa, is a neutrophilic bacteria, so it thrives more in neutral conditions. In addition, diabetics secrete less lysosomal enzymes. These are antimicrobial enzymes. So in the absence of these lysosomal enzymes, lysosome enzymes, the ear becomes less resistant to fighting bacteria and fungi. Now, malignant otitis externa is very, very rare. It's stipulated about 0.2 to 1.2 cases of patients who attend ENT audiology per 1,000 actually have this condition. And the majority of cases of malignant otitis externa are preceded by iatrogenic trauma to the ear, whether that's inflicted by the patient, by poking and scratching in the ear. So as mentioned, if you cause trauma to the delicate skin line in the ear canal, an infection can then spread via those natural openings in the cartilage called the fissures of Santorini to the surrounding bone, or also by irrigation, so trauma caused by having your ears cleaned using water, irrigation. So the typical symptoms of malignant otitis externa is if you have an ulceration, so part of the skin missing, otorrhea, which this patient does have, inflammation and swelling, which this patient does have on the anterior canal wall. You can see what I've done here. I've curved the end of the fine end, so I can get access to the front portion of the eardrum and the anterior recess, because this part of the ear canal here, it is swollen. There's some granulation tissue there. Now, another hallmark clinical sign of malignant otitis externa is granulation tissue, but typically it arises from the floor of the ear canal where the cartilage portion meets the bony portion. So that's where that fissures of Santorini are, those natural openings. Now, there's no granulation tissue in this patient in that region, but I did have a discussion with an ENT consultant recently, and they said you're still got to be careful if there's granulation tissue at other parts of the ear, so it's not to rule it out. Other symptoms, as explained earlier, patients experience acute ear pain, particularly at night, and the reason why the pain is more significant at night is due to our bodily rhythms, our circadian rhythms, and due to our circadian rhythms, at night the immune system releases more cytokine storms if you've got an infection, which then increases inflammation, and more inflammation you can get more pain. Also, there's less cortisol secretion at night, which is an anti-inflammatory effect, and also endorphins. So endorphins are hormones secreted by the body, and they act like a natural pain reliever. Some patients with malignant otitis externa can also develop facial palsy, so one side of their face loses its kind of ability to flex muscles and chew and talk, so you kind of get a droopiness on one side of the face. Now, patients who have otitis externa and who do not respond well to topical treatment for about a week should always be considered whether they've got malignant otitis externa, even if they're not diabetic, even if they're not immunocompromised, even if they're not elderly or they've had previous radiotherapy around the ear. So this patient has already been seen by accident emergency and they've got an ENT appointment due. So what we did today, after I cleaned as much as possible, now it wasn't possible to clean everything, and near the end the patient did twitch slightly when I removed some skin off the eardrum, and it got a bit of clarinetting, so we left that. But what I've done, I've actually contacted their GP practice today. I managed to get their email address and I've sent over a referral, and This patient is to arrange immediately after the Christmas break to visit their GP and get an ear swab. It's important that they have an ear swab to see which strain of bacteria this patient has, because if it is Pseudomonas aeruginosa, then this patient potentially could have malignant otitis externa. In terms of medication, the most effective medication is ciprofloxacin. They appear to have a better ability to fight off gram-negative bacteria than your normal kind of antibiotics given for ear infections, so like neomycin, for example. But although this patient's symptoms did improve, naturally it's going to improve somewhat because we've cleaned the ear. If they're still experiencing their symptoms, particularly at night, the pain, and it happens in the next couple of days, I've just asked them to reattend accident and emergency without taking any risk, and I've sent the patient a copy of the letter by email as well, so they can provide that referral letter to the A&E department, because although the ear was blocked, there was so much pain experienced by this patient. You wouldn't normally anticipate that much pain. So just got to be careful. So if you are diabetic, elderly, and you're immunocompromised, or you've had radiotherapy on the ear and you have an outer ear infection, you've just got to be really, really cautious. I would also recommend in those populations, don't undergo ear irrigation. I'm not a big fan of ear irrigation anyway. If you've been watching my channel over the years, I'm not keen on that, but it is part of the NICE guidelines in the UK, and I know a lot of people do it, so I'm not knocking people that do it. It's just something that I'm not very keen on. For these kind of cases, really. Now, of course, if you're an experienced practitioner in earwax removal, you would be able to highlight the patients who are suitable for irrigation and not. But I know some specialists solely rely on irrigation, which I think it's good for them to get trained in microsuction and also manual instrumentation cases like obviously this. So I'm just peeling some skin from the floor of the ear canal here. I just want to mop up as much as possible for the patient, just so when they do receive treatment, it's going to have better penetration. Initially, I was a bit worried about a cholesteatoma because there was obviously a lot of discharge, otorrhea on the eardrum itself, and a cholesteatoma is a dead skin cyst, and it can develop in the ear canal itself, but there's no evidence of that here. But if the patient has a retraction of the eardrum, so if part of the eardrum is sucked in, it's typically the top part, the attic, or in the case of the right ear that you're seeing at the moment, it's the northwest region. This is the patient where the patient slightly flinched, so I just came out of the ear very quickly there. And I just went back in and everything's fine. So I just decided to leave that region. There's some kind of debris on the anterior part of the eardrum, that it was very difficult to access because of that swelling you can see on the right hand side of the ear canal. I tried my best, I bent the fine end, but couldn't get access to that. So hopefully the antibiotics will do the trick, and if not, and once the swelling goes, we can always mop that up afterwards. There's just some crusted skin here, front part of the ear canal, the superior, so just mop that up. I think we're just going to clean a little bit more up and then we're all done. So that's the patient's eardrum. It's just because of the humidity of the infection, it's just blaring up a bit. If I put the suction probe in, then it will dehumidify.